Professor Singh, thank you again for being here with us. We know it's a little earlier for you, at least it's summer, so, you know, and again, thank you so much for being with us and supporting us in all these initiatives you've seen in the presentations. Professor Arun Singh has been involved in all of them.
Well, thank you so much. It's a pleasure to participate. Thank you to Melina, Rubens, Patricia, Cecilia, Marianne, Aline, Alexa. Did I miss anybody? Everyone. Okay.
Yeah.
Thank you. So in the next 20 minutes, we're going to talk about unusual conjunctival tumors. Let me come back here. I'm from Cleveland Clinic, we'll leave that aside. But when we think about conjunctiva, the layers of conjunctiva, the epithelium and the stroma. Most of the tumors that we see or talk about are the epithelial tumors. They're the most frequent. They're also of limited type. You can say they could be squamous or melanocytic, and you have papilloma, CIN, nevus, panmelanoma. These are the most common conjunctival tumors, but one can say they're a very limited variety, and that is the atypical or the usual conjunctival tumors. If you look at the other layers of the conjunctiva, which is the stroma, and these tumors are rare. And the stroma has a large variety of tissues, and you can have tumors that are neurovascular, lymphoid, myogenic, fibrous, histiocytic, metastatic, inflammatory, and all kinds of masquerades. So this is a large variety of rare tumors. And these are difficult to diagnose because we don't see a lot of them. Anyone can diagnose CIN, but you cannot diagnose leiomyosarcoma of the conjunctiva on examination. So that's why I thought I will emphasize the unusual conjunctival tumors. So think in layers. Let's talk about the case number one. It's a 17-year-old female with a large red vascular lesion, present for 3 months. Before she came to us, she already had an MRI, etc., of the brain and was all negative. Vision was normal. She had no other anomaly. And this is what you see. You see the circumlimbal vascular channels. I thought it was one that photograph. Huh? Rubens, this is coming close to your level, okay? I know you provide very beautiful pictures.
Because I know the case. If you want me to give my brilliant opinion, I can, because I've learned from you, but this is a beautiful case.
What is important here to understand is that these vessels do not go to the fornix. And seems to be just around the cornea or around the limbus. So things like cortico-cavernous fistula, some orbital pressure, those don't come in the diagnosis here, okay? So what did I do? I did the Fluorescein angiogram of the conjunctiva. And on the Fluorescein angiogram, there is no flow in these vessels. These are dark. If this was an artery, it would be bright, and if it is vein, it would be bright, but it's not. So what kind of vessel is it then? At the Rubens has the answer. I can hear him from his lips. He says it's lymphatic. There's no flow. So we said, well, this could be lymphangiectasia or lymphatic channels that are full of blood. So what did we want to do? So this is a young girl. She's bothered by the cosmetic. So we thought we will drain or cut the central part and see how she goes. And then we start the surgery, and I think I have a video here. So my intention was to cut this piece off. And when I start here, I start to see the vessels kind of bleeding with the cut edge. So I started to cauterize them and cut them. So this was the plan. This was the plan to cut the conjunctiva. but I stopped. I started to make snips on the conjunctiva and press it, you see, empty them out, like emptying the sausage, okay? Just cut them, slice them a little bit, snip them into the vessels, and cauterize some of them. That's what I did. Plus, I took a slight crescent here for the pathology, and that's important. And pathology showed dilated lymphatic, so that confirms the diagnosis. And this is what she looks up on the first post-op day. There's a large contact lens. This is what she looks many months later. This is the surgical site where I took a pathology sample. So although you don't see the vascular channels, you still see these channels on the OCT. Because the lymphatics are still there, they're abnormal. All I did was empty the blood out of it. So this is the hemorrhagic lymphangiectasia. Let's go to the next case. 60-year-old lady with history of sarcoidosis. She has a known history of sarcoidosis. And on examination, she has an incidental mass, kind of where the caruncle is. Here's the caruncle in the plica and behind, over the medial rectus, she has this yellowish, pinkish, multinodular mass. That's not on the surface, it's on the deeper side of the conjunctiva, appears to be stroma. It was partially mobile, and one could see that it wasn't going very deep in the orbit. And we did the scans, etc., to show that it was lying on front of the medial rectus muscle. So here's the caruncle, here's the plica. So it's kind of behind in the plica and the medial fornix coming from the inferior orbit. So the differential diagnosis, of course, you say it can be sarcoidosis. Yeah, it can be sarcoidosis. I put down xanthogranuloma because it had the yellow look. And I put lipoma to tell you that there's nothing like orbital lipoma. There's no such entity. So don't think of orbital lipoma, okay? It doesn't exist. But we can have sebaceous adenoma and sebaceous carcinoma. These ones, we know, can arise from caruncle and backwards. And so this is an important consideration. So you really have to remove it, which we did. And when we sent for pathology, it has the typical appearance of amyloidosis with apple birefringence, classic of amyloidosis. So sarcoidosis, sarcoid, amyloid, and lymphoid, all three go together. Sarcoid, lymphoid, amyloid. They all look the same clinically, but pathologically, of course, they're different. So this was amyloidosis. And then we subtyped the amyloidosis, trying to find out which kind of amyloidosis it was. And it was what we call AL kind. AL. So it's we did the mass spectrometric analysis to show that it was composed of immune globulin proteins. And most of it, I would say all of the adnexal amyloidosis is immunoglobulin derived, and therefore these patients are at a risk of getting multiple myeloma-like disorders. And they so all cases of ocular adnexal amyloidosis are immunoglobulin. We had 10 cases, we reviewed them all, and then we reviewed all the history, published cases, and each one is a case report, but if you line all them up, they all come back as immunoglobulin, but you need to do mass spectrometric analysis to find out the exact composition. So when you dig a conjunctival amyloid sample, they need a special test. They'll say amyloid, but to know what kind of amyloid, you need mass spectrometry. It's available in many good labs, and it's a routine procedure. Let's talk about a third case. He's a 40-year-old dentist. He's noted some redness in the eye for almost 2 years. Didn't pay much attention, vision is 20/20. And you can see here, which looks like a typical CIN, one can say it's affecting half the limbus. There is a Some conjunctival component not very prominent, but their corneal disease seems to be very striking. So this is an easy clinical diagnosis, no worry about it. So you say, well, I'm going to cut off all of this. I would say it'll be too much of surgery here because you're going to cut more than half the limbus. In a 40-year-old, you may have some issues with limbal stem cell deficiency over time. And it's ill-defined. You don't know where in the conjunctiva it ends, but how much are you going to cut? So we classify this as diffuse disease. And for diffuse disease, we try to do immunoreduction or chemoreduction to help reduce the size before you do the surgery. So this is many years ago. We did mitomycin on him. You can see just with one cycle, you can start to see the corneal component goes away. And that's the first one to solve. So we continued with 4 cycles. By the time we see the corneal disease is all gone, but he's starting to get toxicity, and we understand that. But nowadays, we will use preferably interferon, so you will not get toxicity, a similar reduction. So now that we've reduced or eliminated the corneal disease, you're left only with conjunctival disease. You see that here? At this point, I went and removed the conjunctival tumor. So this is chemoreduction, immunoreduction principle. And we have published a small series on it in the past. And then when we did the pathology, he has a scleral invasion. You can see the tumor coming into the sclera. Don't forget, he had history for 2 years. In the US, it's very unusual for CIN to invade the stroma and to make it invasive carcinoma. I know in Brazil and other parts of the world, invasive carcinoma is not rare. This is not the common thing that's in the clinic. But this is only if you start to do a good pathology and try to see the deep margin. We see the deep margin on the scleral side was positive. So now what are you going to do for them? We say we can observe. I don't think that's a good idea because this will grow and can grow inside the eye. You have intraocular extension. You can say, well, I will try some more mitomycin or interferon. Well, it's not going to go into the stroma of the sclera, so that's not going to work. And you say, I will do surgery, but you don't know how deep to go. And you'll cut the sclera 80%, and then you're going to get staphyloма and poor healing in a 40-year-old person who's going to have a lot of complications over time. So your real treatment here is brachytherapy, is radiation. You really have to go and treat it with radiation. And that's what we did. We put a plaque on it, and here's a photograph. And just to make it comfortable for him after surgery, you put tryptoplas temporarily, do tarsorrhaphy, leave it for 72 hours, give the dose of about 25 gray, depth of 3 millimeters. So 1 for conj, 1 for sclera, and 1 little extra. And you go out to the depth of 3 millimeters. So you're really going into the vitreous, let's say. Huh? And this is many years later, 5 years later, and you can see there's no recurrence, some vascular anomaly from radiation, maybe one tiny little cataract, but no recurrence ever. So the point here is that when you have scleral invasion or stromal disease, you really think of brachytherapy. Okay. And just very briefly about topical therapy, you can use it for diffuse disease. You can do it before excision or you can do it after excision if the positive. And we all know about these kind of things. So here's a patient with extensive corneal disease, you can see, and after treatment, we got better. This is the CIN, here's the pathology, and this is after interferon nowadays. You can see within 3 months, it's all gone. So for corneal disease, certainly this is very useful. Am I still there? You can still see my slides, yeah? Okay. Case number 4 is a patient. Am I still there?
No, not anymore.
Okay, let me see that.
You just have to share again, Dr. Singh.
Sorry,
please.
let me go back here.
I'm sure it was the Brazilian's fault, not your fault.
Okay, here we go. So here's a 22-year-old African-American female. with NF1. So Cecilia presented of phacomatoses, this is NF1. And she came after having
Still
a
didn't get it.
biopsy
Sorry,
that
Dr. Singh.
showed conjunctival melanoma. So a 22-year-old, too young to get melanoma, African American, very unusual to get melanoma.
Dr.
Fortunately, she already had a sentinel lymph node biopsy, was negative, and she had been advised exenteration.
We are not seeing your slides. I'm sorry. You have to share again. We're seeing your video, but not your slides.
Okay, let's see here.
Try again.
Yeah. Okay.
Nope. Yeah. Now we have it.
Okay, let's start again from here. Yeah.
Yes.
Okay. So it's a 22-year-old African American female with NF1 with a biopsy proven melanoma. So it's unusual to have it in 22-year-old, too young, African American, also unusual to get melanoma. But NF1 can rarely be linked to cutaneous melanoma, but this is conjunctival. And she had been advised exenteration, which is kind of drastic for a young 22-year-old. And so she came looking for an option. Here you can see the pigmented neurofibromas of NF1. And what you can see here on the conjunctiva is bilimbal melanoma. Melanoma here and melanoma here. This is where the biopsy had been done, and this is not pyogenic melanoma. This is recurrent melanoma. So she has bilimbal melanoma. So the OCT doesn't show anything, but the UBM shows you it's coming into the cornea here and going into the sclera. You know this melanoma is in. So you can cut as deep as you want, and you'll have got the same problems. You'll cut the cornea here, you'll cut this. You'll have very thin sclera left at the end. And you do not know where you are, am I going to get negative margins and things of that nature. So in any case, we confirmed the diagnosis with a superficial biopsy was melanoma. And then I did bilimbal plaques. So I put a plaque on one limbus first time, one side. And after 72 hours, remove this plaque and transfer to the other side. These are the various of the same eye for two different sides, talking about dose distributions and things of that nature. And this is what she is. You can see, looks pretty good. Don't see any melanoma anywhere. All the pigmentation. You can see she is smiling, even behind this. She's dyed her hair and having good life. This is not side effect of radiation. Just felt good and just changed the color. That's all. But you can see from her lips, smiling. Beautiful young lady. So this is bilimbal melanoma treated with bilimbal radiation therapy. So I want to talk to you to the last case. The 50-year-old Hispanic. So I'm telling you all kinds of American people. Caucasian, African American, and now Hispanic. So this man had history of renal transplant and has had a recurrent conjunctival tumor. And he has been excised twice already in different places. One place, the diagnosis was ocular surface neoplasia, CIN, invasive carcinoma. And the other place, it was malignant fibrous histiocytoma. So two biopsies, two diagnoses. But remember, he has renal transplant. And with renal transplant, people are immunosuppressed. And when they're immunosuppressed, they can get, of course they can. They can get undifferentiated lymphomas. We know that. And they can get some other rare tumors as well. So that is a risk factor here. Let's look at him. This is after 2 surgeries. He's still got tumor sitting here. Okay. The cornea is partially involved. The lids are okay. You see some mucus discharge, but here's the tumor. So we excised it. And our initial diagnosis was leiomyosarcoma. but later on it was changed on technical staining, etc., to myofibrosarcoma, which are related. But leiomyosarcoma is known to happen in people who are immunosuppressed. So I have no doubt that that's the reason why he got this tumor. He has scleral invasion, so excise it, put it away, and put a plaque on it. And this is what it looks 3 months later. Very beautiful. But it's only 3 months. And then he comes back with a recurrence along the superior margin. You can see the tumor here. Margin, the recurrence happened on the top. So I excise this again and put the second plaque. And guess what? Another 3 months, he gets a recurrence of the bottom. And I put the third plaque. I told him I'll go up to 4 or no more. So this is 3. After 3 plaques, he has no tumor, 2 years follow-up. Of course, he has cataract, expected. So I sent to my wife, she did the cataract surgery, she was happy to get a patient. She was cataract surgery. He did. He looked good. This is what he looks like after 24 months. The lid's in good position. Now he's pseudo-phakic. Lids are okay, conjunctiva okay. And I thought, let me show people, they want to know about radiation retinopathy. So he's now 5 years out, almost. I did fluorescein just to show that he has no radiation retinopathy. And by the way, you will not get it because the dosing is only up to 3 millimeters. And you're not going to reach beyond aura at all. It's going to be all just dying down in the vitreous. And here's the OCT, here's the fluorescein, here's the vision. 2022. Okay. So, what's the summary? The summary is that if you see lymphangiectasia, you can drain it. You need immunohistochemistry for some of these cases to make a correct diagnosis. You can do special studies like OCT, we don't talk much about that, but UBM to see the depth. And also in unusual vascular tumors, you can do conjunctival fluorescein, and you can. And we do them for iris tumors also. So you can do anterior segment fluorescein angiogram, same camera, same everything. And then remember, for some conditions, you need to do systemic workup for amyloid. Almost all, I'll say 100%. They are immune globulin protein amyloid. You need to look, 10% or so will have multiple myeloma-like disease. And then for when you have scleral invasion, either with squamous cell carcinoma or with melanoma or with other rare tumor, the answer is adjuvant radiation. That is the key. And when you're thinking of conjunctival tumors, don't only limit yourself to the usual common tumors that we can handle, but don't forget vascular tumors, myogenic tumors, fibrous histiocytic tumors, and inflammations that can handle conjunctival tumors. Thank you again for allowing me to contribute.